Good afternoon. I am not Tom Farden. I'm Sarah Ulster, for those who don't know me, a consultant in sexual health and HIV, and I am filling the large shoes of Tom today, who is probably in some kind of biking shoe. Um, Delighted to welcome the antimicrobial team here. I think no matter where you work in healthcare, it would be quite unusual if you weren't prescribing antibiotics. And so I think this is a really key learning event for all of us. I'm glad to see that we're recording this because unfortunately, I think turnout might be affected by the fact that an email didn't seem to go out today, possibly linked to Tom being on annual leave. So hopefully people will access this recording at a later date. I can already see that doxycycline is down there on this even title slide, so already I'm feeling guilty about prescribing. But hopefully this talk will shed some light on what we're doing right and what we can improve on. So yeah, welcome in particular, Joe McEwen and Heather Kennedy from the Antimicrobial Stewardship Pharmacy team, and hoping for some cameos perhaps by Dr. Brucey Moka and Kirstine Hill, and maybe others over the course of this session. So I'm going to hand over to the team now, and hopefully we'll have time for questions at the end.
Good afternoon. Apologies for that. And thanks for the introductions, Dr. Ulster, as well. So I'm Jo McEwen. I'm the lead antimicrobial stewardship nurse for NHS Tayside. And with me, I have Heather Kennedy, who is the advanced antimicrobial pharmacist in NHS Tayside as well. So as Sarah's very kindly informed you, we are going to be running through some antimicrobial stewardship hints, tips and awareness, and showcase some of the work that is going on within NHS Tayside, and really in a plea to promote Antimicrobial Stewardship Awareness Week, which takes place from the 18th of November to the 24th of November every single year. So before we begin, dotted throughout some of the slides, you will see very strange emojis and the name of an antibiotic throughout the presentation. So this is just a check to see that you're paying attention, and the emojis depict a side effect of these antibiotics. So we will be testing you, and at the end we will give you the answers to this. So pay attention. So antimicrobial resistance has been termed as a global threat, as it changes are needed to keep antibiotics working. In 2016, Jim O'Neill, who's a World Health economist, was asked by the UK government to put together an economic impact statement and report around how antimicrobial resistance would affect us at not only a UK level, but at a global level. And the figures that were projected are quite alarming. So it's projected that by 2050, which isn't that far away, 10 million people will die every single year from antimicrobial resistant associated infections. So this is more than cancer and diabetes combined. And that in itself is alarming. And at a staggering cost of around £66 trillion every single year being attributed to antimicrobial resistant infections. When we think about antimicrobial resistance, it has also been coined as the silent pandemic. And we within health are all too aware of the actual pandemic we have lived, breathed over the last 4 years. And when we think about the COVID pandemic, to date, over the last 4 years, around 7 million people have died as a result of COVID. So when we're talking about antimicrobial resistance, this isn't just one organism, this affects many organisms, and sadly our death rate and our toll and our mortality and morbidity associated with this is going to be much greater. We will also have media interest around this, and already we are beginning to see the alarming impact of antimicrobial resistance within our social media and our news streams as well. So for the first time, or for only the second time in history, in 2016 as well, antimicrobial resistance was discussed and led at a UN high-level General Assembly. The only other time that a health matter has been discussed at a UN high-level General Assembly was in the early 80s when we were discussing HIV and AIDS. Now, antimicrobial resistance and the global impact and threat has taken another headline because we're on the second time that this has been discussed at a UN General Assembly just in September this year. So this demonstrates the commitment and the collegiance that isn't required at a global level to combat antimicrobial resistance. We can't do this on our own. We need all key stakeholders at a global level to be involved and engaged and implement key antimicrobial stewardship measures to minimise the incidence of antimicrobial resistance as we move forward. So at this as General Assembly, the world leaders committed to reduce deaths from antimicrobial resistance by 10% by 2030. So when we take this into a UK context, just earlier this year, the UK government launched their revised 5-year National Antimicrobial Resistance Action Plan, confronting antimicrobial resistance, which takes us up to 2029. And where we are within Scotland, this is led and contributed to through the Scottish Antimicrobial Prescribing Group and Scottish Government, where we are awaiting our Scottish action plan from Scottish Government, and that is fed into the local antimicrobial management teams across NHS Scotland. So some of the elements that we're looking at in the National Action Plan around optimising the use of antibiotics will not be unfamiliar to you, but it's strengthening those messages and it's broadening the remit and scope and implementation across all healthcare and social care delivery care settings. So what we're looking at is to reduce antimicrobial usage and make the usage more appropriate. We want to reduce the need of unintentional exposure to antimicrobials. We want to optimise the use of antimicrobials as well. And you can see from this slide that there are several key ambitions that have been set out within the National Action Plan that we will be working on both at a national and a local level as we take this action plan forward to 2029. So that brings us down into our local antimicrobial awareness week sessions. So from the previous slide, you have seen that there is an emphasis around ensuring that we engage all individuals involved in health and social care in antimicrobial stewardship and resistance awareness and education, that it is embedded within workforce, and that we have appropriate governance structures around all areas of care delivery to support good antimicrobial stewardship across all professions. So this year, the antimicrobial management team have taken the decision to promote the themes of the World Health Organization for Antimicrobial Awareness Week. So we'll take you through some of these themes as we move forward. So infection prevention and control and antimicrobial stewardship, although two very distinct teams and work independently of each other, they require to be aligned and to work in harmony with the other team to ensure that we don't see an increase in resistant organisms spreading within the care settings that we work within. And likewise, we don't want to see an increase in our antibiotic usage driving resistant organism development. So we have a link, although we are very distinct and different teams. So how do we work together? Well, we need to prevent the risk of spread of resistant organisms. We need to make sure that we are working collaboratively to optimise outcomes for the people that we care for across all care delivery settings. Education and engaging healthcare staff, again, across a variety of different healthcare delivery settings. From an infection prevention control perspective, a large amount of resource is implemented into monitoring and surveilling our resistant organisms, our E. coli bacteremias, our Staph aureus bacteremias, our rates of CDI and surgical site infections as well, and monitoring other alert organisms that may impact us at a health level. Collaborative work around policy and guidance development is essential as well. So in practice, from a healthcare perspective, what we would be looking for is ensuring that we adopt as healthcare professionals the infection prevention control standards for every patient, every time. So we have 10 standard infection control precautions. So making sure that we are appropriately placing our patients within our wards and environments if we have a known or a suspected alert organism. We want to manage the care environment and equipment that we are using in the delivery of patient care to ensure that it's safe, it is decontaminated effectively, and we're not indirectly transferring organisms to people inadvertently. The appropriate use of hand decontamination, so hand hygiene, is critical and is still coined as the single most important way and means to minimise the spread of infection. Using appropriate PPE is critical in minimising the spread of infection as well, and ensuring that the care and the subsequent removal of invasive devices that aren't required, such as urinary catheters and peripheral vascular catheters, is thought of and considered at the forefront and is not an afterthought when it comes to patient care, as these can lead to E. coli bacteremias, they can lead to Staph aureus bacteremias, and in fact in NHS Tayside, our Staph aureus bacteremias, our leading cause of Staph aureus bacteremias are PVC infections. Other areas where we can be involved in infection prevention control are around contributing to the review of our SABs, our ECBs and our CDIs. The inclusion and the expertise of medical staff can't be underestimated, as that brings a completely different dynamic to the review, and it ensures that the outcome is informed and is balanced. So from our perspective, we would urge all medical teams to get involved in those reviews if requested to do so. Optimising diagnostics is another area that is critical to promoting good stewardship. Apologies, this slide is quite busy and I don't expect you all to read that, but we do like a sample when we work in healthcare, but we really need to think about when samples are taken and should only be taken within the presenting signs and symptoms of person's illness, and ideally taken before antimicrobial therapy is started if possible. Critical is skipping the dip. Within secondary care, there is little to no value in the diagnostic use of urinalysis in diagnosing UTI, and certainly not catheter-associated UTI. And this was emphasised and highlighted in a recent JAMA publication as well. Making sure that we're taking our samples in a timely manner so that we can accurately and promptly aid diagnosis. Considering previous sample results is critical when starting empirical treatment. Have we had previous samples where there has been resistance to their empirical therapy that we are opting to use? When it comes to blood cultures, the gold standard is to obtain 2 sets. In Staph aureus bacteremia, we need to repeat those blood cultures at regular intervals until we get a negative result. For those colleagues working in surgery, timely source control reduces exposure to antibiotics. And when it comes to swabs for culture and sensitivity, they're typically poor diagnostic tools, and alternative samples such as tissue and fluid may be more valuable in promoting and aiding that diagnostic intervention. So I mentioned around skipping the dip, and one area that we have tried to promote that locally is around the grant-funded Optima UTI project, which has been implemented within 4 clinical areas in 9 wells, so AIM, AMU, ASRU and acute frailty unit. The grant-funded project aims to optimise the outcomes of people with urinary tract infection and COTI admitted to hospital. It is a multi-professional and multi-departmental programme. The intervention itself focused around the recognition, the diagnosis, including the diagnostic stewardship elements, and the management of catheters, product selection and care and maintenance. So the intervention phase has just concluded last week, and we are currently working on the data analysis. The learning resources from this have been incorporated into our wide-scale board E. coli bacteremia programme so that we can reduce our incidence of E. coli bacteremia. So a key intervention that we took within this was to change the dipstick product to remove the possibility of leukocytes and nitrites to avoid inadvertently using this to drive UTI or COTI diagnosis, where there is very little value. So what does this all mean to us at a local level? So as I mentioned at the start, we are awaiting our Scottish action plan, but from the UK National Action Plan, we know that we have 2 human health targets. We have an aim by 2029 to reduce the total antibiotic use in human populations by 5% from the 2019 baseline. And by 2029, we aim to achieve 70% of all of our antibiotic used to belong to the access category. So those of you that are not familiar with access, it belongs to the aware category, which is access, watch and reserve, which is almost like a traffic light system of green, amber, red. So we want to be using those green antibiotics, those antibiotics that are first line within our local policies and formulary. So across primary care, as with the rest of Scotland, our antibiotic usage has risen since 2019, following on from COVID. Although the good news is, over the last few weeks, our antibiotic usage has started to plateau ever so slightly, but that doesn't mean that we should become complacent around that. We do still have efforts and interventions that can be made and introduced there to reduce our overall prescribing rates. Within secondary care, we're the second highest mainland board in our total use of antibiotics. So again, concerted efforts required across all areas within secondary care when we look at our total antibiotic use within secondary care. But there is some good news. So when we look at the access prescribing, so what we are prescribing, not the volume of what we are prescribing, NHS Tayside is leading the pack. We are the best in class when it comes to our use of access antibiotics across all healthcare boards in Scotland. So as you can see from the graph, we're sitting at just under 71% of our total antibiotic use belongs to the access category. So if you remember a few slides back, our aim and our target by 2029 is to achieve 70% or greater access antibiotic usage. So we've already achieved that target. So now the competitiveness in me and our team, we want to excel. We want to improve that even more. I'll pass you over to Heather.
Thanks, Jo. So as part of our team, we think it's really important that we share some of our work and that we communicate out with teams. So one of the things we do after every antimicrobial management group meeting is we produce one of our key messages bulletins. Now these bulletins go out widely to all staff. This is just an example of one of our bulletins which highlights some of the resources that we have developed recently. So we'll go through some of these resources in a little bit more detail, but this one as an example, hopefully you will have seen all of these resources are available on our website, and it gives you a little bit of a picture at the bottom here of exactly where to find them on our website. So the first one is a resource called SODAPOP. So we do like an acronym in our team, I'm afraid. So SODAPOP is aimed at secondary care, and basically it's a document that highlights key stewardship messages that we would expect prescribers to keep in mind when they are prescribing antimicrobials. So there are links there next to every letter. It gives you a little bit of information around orals, durations, thinking about alternatives, a little bit around allergy, penicillin allergy delabeling. Again, as Jo mentioned, optimizing diagnostics, which is key, and also our policies and where to find them. So the QR code on the screen will allow you to find that on our website, but this actually links from the homepage of our antimicrobial website, and it's based for secondary care prescribers. Similarly, we produced one called Popstar for our primary care colleagues. So if there's anyone in the call here from primary care, this will be, it isn't yet, but it will be later on today, posted on the primary care link from our antimicrobial website. And again, it just highlights key themes, stewardship messages that we would expect prescribers to bear in mind for every person every time they are prescribing. And that just helps the overall awareness of stewardship within primary care. So we would encourage all staff to download the Right Decision Health and Care app. This has replaced the Antimicrobial Companion app that was in circulation before, but we would ask that all prescribers download this. It is hugely helpful. Everyone carries their phone with them all of the time now, certainly at bedside, and it is one of the ways that we are promoting prescribers to link with our guidance. When you download this app for the first time, you search for a toolkit. So we've put at the bottom left there that you search for the NHS Tayside antimicrobial prescribing toolkits. Once you've searched for that, if you hit add to my toolkits, it'll be there next time you go into the app. When you go into NHS Tayside, this is the home screen that you will find on the app. And as you can see, there's loads of information available. We have both the vancomycin and gentamicin calculators, which are the ones specific for NHS Tayside that we would promote prescribers to access. The hospital guidance link there links to the homepage of our antimicrobial website where you can find all of our guideline documents. And there's other bits and pieces as well on that app. I just wanted to note a slight caution, if you like. Please, to prescribers or anyone, please don't Google gentamicin calculator or Google the Right Decision gentamicin calculator. There is a risk, and we are aware that this has happened previously. You might click on the wrong calculator. There are 2 calculators in circulation across NHS Scotland, and the one that is pertinent to us sits on our website, on the antimicrobial website, or it sits in the NHS toolkit on the app. And those are the 2 ways that we would promote prescribers to find that calculator, rather than Googling it, which we know has happened in the past and led to some errors. So we do ask that you're just a bit mindful of how you find the gentamicin or vancomycin calculators. This is a little bit of a hot topic just now, as Aztreonam is mentioned over and over when we think about IV use. So the reason it's a little bit of a hot topic just now is because of the supply issue with Aztreonam over the past few months. Now, supply is always precarious with Aztreonam because we only have one supplier coming into NHS Tayside. We have had many shortages over the years, which we've dealt with. But earlier this year, we got a Department of Health warning about a potential long-term stock outage of Aztreonam. Since we've had that, we are still fulfilling some orders. So we're expecting updates. We're working on kind of the information that we have to hand, but we have minimal stock. We do have some stock still in. But our team is looking at this as a positive. We are looking at this as a way to promote stewardship messages, and we need to be less reliant on Aztreonam anyway. So we're looking at this as an opportunity to look at other agents, other stewardship means, IV to oral switch, which we'll come on to, and we're trying to remain positive about Aztreonam. We have a shortage document on our website, and we have a shortage document for lots of lines, but certainly for IV Aztreonam, we have rewritten that and updated that recently. So it gives, again, prescribers some information about what to think of if we have no Aztreonam in stock. It gives some information around alternative agents to think about for certain indications. And one of the things it promotes is this idea of gentamicin for 96 hours. That is something that our antimicrobial team has considered when we heard about a potential Aztreonam shortage. So essentially what that would mean is that where previously and at the moment we ceiling gentamicin at 72 hours, we would extend that to 96 hours. Now that doesn't mean patients need 96 hours of gentamicin. It means they could have it if it was deemed appropriate. We know this happens safely in other boards, so we are not doing something that is not mirrored, certainly in other specialties across Scotland. This is our gentamicin prescribing chart that we currently use, and as you can see, it has been updated to allow a 4th line if that's appropriate for the patient. So when we move to that in a few weeks' time, we're just looking at all means to deal with a potential Aztreonam shortage. This may be something that is communicated out to all prescribers as something we want to implement. But this is what the gentamicin prescription chart will look like. So if we start to think about resistance and the wider environment, One of the ways we can start to tackle IV antimicrobial resistance, and certainly a sustainability and an environmental factor, is starting to think about our IV use. When we look at the data that we have here up to Q1 this year, we can see that Tayside as a board has a higher IV antibiotic use than NHS Scotland. So we are a high user of IV antibiotics across our board, and we need to look at ways to try and bring that level down. Also for the good of the patient, from an IV to oral switch perspective, but also from a waste perspective. So this screen highlights 1 dose of amoxicillin, metronidazole and gentamicin, and you can see the amount of waste, the plastic that is associated with just that 1 dose. Now, amoxicillin and metronidazole are both 3 times a day drugs, so we will have even more if you think of a full day's treatment. So this is 1 dose versus 1 oral cotrimoxazole tablet. So from a waste perspective, we really need to start thinking about our IV usage and why and how we are bringing that down. One of the ways is to promote highly oral bioavailable agents instead of, or for prescribers to be aware of them when they are putting patients in IV antibiotics. The QR code at the bottom left of your screen links to another of our resources that we developed around bioavailability, which is on our homepage on our antimicrobial website. But when you think of some of our commonly used drugs, metronidazole and Cotrim at the bottom of that slide, they are almost 100% bioavailable. So when prescribers are prescribing IV metronidazole or IV Cotrim, we do now ask that they consider oral for these, and some of our empirical guidelines have been amended so that it's IV/PO to think about oral, especially in these drugs, and that'll help our overall IV usage within NHS Tayside. In order to safely switch a patient from an IV preparation to an oral, we do use the home criteria. And again, our IVOS policy and our home criteria is on our website. So the home criteria just asks prescribers to think about if the patient is hemodynamically stable, is their oral route available, markers of infection improving, so are they trending towards normal, and certainly we need to think about or exclude deep-seated infections and the source, which may require IV prolonged therapy. But home criteria is what we would use for all patients in our aim to get them off IVs as soon as appropriate. So when we think about antimicrobials in the wider environment, Scotland was one of the first countries to think about a One Health approach. And all that really is thinking about where antimicrobials factor into the wider healthcare system. So from farming to the food we eat, to the water supplies coming in, how they all link to that antimicrobial resistance message. And you can see from the diagram here, we are all interlinked with exactly food that we buy into the country, farming, water, swimming. We are all affected and linked. Antibiotics don't just affect the person receiving them, they're one of the only classes of drugs that affects everyone. And we couldn't talk about animals and pets without introducing us to our team mascots. These are Joe's dogs on the bottom right, that's Bailey and Bally, our award-winning team mascots. So we love them, we had to get them in somewhere. So the next part of the WHO theme really was talking about allergy, and more importantly, untrue or spurious allergy. For the sake of this presentation, we will focus on predominantly penicillin allergy because it's the most common drug allergy that we find certainly within our team. So why does this matter? I'm sure everyone in the call can think of examples where a patient has been labelled as allergic, but when we delve a little bit deeper into it, we found out that nausea, sickness, these are the kind of symptoms that the patient is experiencing. So as I say, why does documenting allergy correctly matter? Well, it can potentially increase duration of hospital stay. It can increase the cost of alternative drugs that we need to use. These alternative drugs might have side effects and complications, and overall, it is this idea of increased antimicrobial resistance. We may need to use broader spectrum agents, which we don't want to use. I just wanted to put a note on here because again, our team was made aware of an incidence around documenting allergies when filling in HEPMA records, if you like. So we know that if somebody has a penicillin allergy and we go to record that in HEPMA, that penicillamine actually comes up as the first one alphabetically. And we know that that is being ticked instead of a penicillin allergy in some cases. So we just urge prescribers to be very careful that all allergies are documented accurately, just to make sure the patient receives that optimal treatment. So within Scotland, and certainly within Tayside, we are the only board to offer a whole system approach to penicillin allergy delabelling. So there's work going on in secondary and primary care around delabelling. Within secondary care, a delabelling service has been in place for quite a while now. We know that it happens with secondary care. We're slightly newer within primary care. We're still piloting a piece of work within GP practices. If you are considering an oral challenge within the acute sector, the SAPG algorithm, so the Scottish-based algorithm, is available on our website, and we do ask that prescribers read that algorithm before they even think about an oral challenge. For a note there, the algorithm is being updated by the national group at the moment, and it may allow a direct delabelling for patients with a low risk. So again, that allergy can be taken off the patient's file and they would be eligible for a penicillin in the future. All patients would benefit from a delabelling service or from if their allergy is not documented correctly, but there are certain areas where patients would extremely benefit, for example, hem-onc and neurology. If we think of the paddle service within primary care, at the moment we have 6 GP practices involved in this work across Angus, Dundee and P&K. Before this work happened, I did a little bit of research around what else is happening within the whole of UK. There is one trial happening, I think down in Oxford, the Alabama trial, but really this is a novel piece of work within Scotland. There's no other board that is taking part in a whole service, delabelling service like we are in Ninewells and Tayside. So we are really leading the way, if you like. Within primary care, patients are identified as eligible for the delabelling service using Vision, which is the GP computer service. Patients' interviews are carried out using the SAPG algorithm from the previous slide, and based on that interview and what they say their allergy is, we can retrospectively delabel them, and the allergy label on the file is amended and removed. If you have any questions or you want to know any more information, or you're considering a patient for a delabel process, there is loads of information on our penicillin allergy link on our website on the left-hand side there. There's the algorithm, there's patient information leaflets, there's the SOP locally that we have developed. So if that's something you're interested in, there is loads of information on our website. So at the start of this, Joe mentioned that for World Antimicrobial Resistance Week, that there are certain themes that the WHO are promoting. Locally, we wanted to put our slightly different spin on this. So for each day next week, starting on Monday the 18th, we are going to focus on a sector of the day. We just wanted to do this so slightly different to highlight the good work and the variety and the scope of practitioners and areas that antimicrobial resistance reaches and antimicrobial stewardship reaches. So we're going to focus on a sector each day. We're going to highlight good work, keep an eye on social media each day. As I say, we're starting on Monday. If you share things, retweet things, if that's even a thing now, there will be comms coming out, but it'll all kick off on Monday next week. Now, for any of you that are still awake and has been taking part in the emoji quiz that's been dotted throughout this presentation, here are the answers. So the doxycycline side effect is obviously photosensitivity. We've got a little fiery sun there. Metronidazole has extreme vomiting. It's not quite extreme vomiting, it's like exorcist style vomiting that happens with metronidazole and alcohol. It can also leave you a metallic taste in the mouth, just to be aware of. Clindamycin is one of the 4 C's, so obviously it has a diarrhea side effect. Rifampicin, it turns all secretions orange, so patients would need to be counselled on that. Sometimes that's a bit of a scare for them, or they get a bit of a surprise, but it does turn all secretions orange. Clarithromycin has a prolonged QT, so again, consider a baseline ECG when you're prescribing Clary. It may be required based on the patient. And I think this is my all-time favourite. If anybody got this, a huge well done. For for gentamicin. So the little ear was obviously ototoxicity, which can happen with gentamicin. And for the little face and the horse, that is renal impairment because it's a kid and the horse goes neigh. So it's kidneys and causes renal impairment. So again, that's our sense of humour in the office. So hopefully everybody got that. Thank you for listening. We are happy to take any questions. There's a few of us all on the call here that haven't spoke. So between us, hopefully we can answer any questions. Thank you.
Thank you very much to both Jo and Heather. Any questions? I'm on the chat just now. There's nothing there, so please speak up if you have any questions. Nothing so far. People stunned. I didn't have any, well, I do have some questions, but I don't know this is the place for them. I thought that it's been really helpful to see where all the resources sit, and to have those resources. I think that's really, really helpful. And I also appreciate the amount of work that goes into that. So thank you very much for signposting us to where we can find the resources, because like a lot of things, we can't keep them at the forefront of our mind all the time, but if we can know where to find them, then that's both helpful and safe. Yeah, I mean, I guess my question would be, in our line of work, we use an awful lot of antibiotics as prevention. And compared to the antibiotics that we use as treatment, do you have a sense for what's the bigger problem? Is using antibiotics as prevention of infection, epidemiological treatment, or post-exposure prophylaxis, for example, malaria prophylaxis, would that be a bigger problem, or is the amount of antibiotics consumed as treatment the big problem?
I don't know if Bussy wants to come in for that. I think, Dr. Also, it's the balancing measure. So within your line of work, preventative antimicrobial use is critical because the consequences of not using that can be catastrophic at a patient level. So it's balancing the appropriate use of prophylaxis and not giving preventative antimicrobials to everyone who may or may not come into contact with something. Do you have anything else to add to that, Bussy? Oh, we can't hear you.
Still can't hear you, Bussy.
No.
Oh, no, there you
no.
are. Yep, we've got you.
That's a shame.
That's
No, we've
it.
got
That's
you.
it. We've got you now.
That's a shame.
No, we've got you now, Bussy.
That's odd. Okay. I think it's very difficult to answer the question as a monolith because some of the preventative therapies have very good data that they don't really seem to affect prevention a lot, like PrEP. So there is some data that is not problematic. Other bits of prevention have really good data that they are quite problematic, such as for urinary tract infection prophylaxis. That's an area that actually we could maybe improve a lot of how we prescribe there. Where we consume our data about prescribing, we don't get a differentiation about why the drug has been prescribed. So when we get the data about, so 80% of our use is in community, 20% is in secondary care. When we're looking at the data, it doesn't actually differentiate by indication. So that's a flaw in some of how we look at our data. So you would probably need to be doing a specific study, looking at a specific indication and following out for what the consequence of prescribing has been. But all to say that it's not the same. The preventive prescribing really does depend on the indication.
Thanks, that's really interesting. Thank you. There's obviously a lot of concern about the use of doxycycline as post-exposure prophylaxis for STIs. Right? There's an awful lot of discussion, and I think we will see increasing use, and whether that reduces overall consumption of antibiotics in the longer term, I guess, depending on which group of people we use it in, but what that might do to community AMR, we await to see. Any other questions? Oh, Oh, we've lost you again, Lucy. What the heck is going on? Do the magic thing you
Plugged it
did
in and
before.
out.
Oh, there.
No.
No?
Oh, God.
Lynn.
Hello.
Hi, Lynn.
Hi. I was just going to say that I think because everyone's overwhelmed with workload at the moment, that there's everyone worries when these kind of things come along that this is something that's adding to your workload, like, oh, we have to think more, we have to do more. But in fact, a lot of EMR is about reducing your workload. Or not AMR, but like stewardship, sorry, is about reducing your workload. So Joe will be able to tell me because I can't remember the exact figure, but there's really good data about the amount of nurse time that's saved when you IVOSed a patient. And actually, in these times of real nursing pressure and when we've got lots of patients, if you IVOSed, I think it's something like 11 times less basically it takes, but Joe will be able to give the exact figure, that if we can just switch someone to a tablet a day earlier or 2 days earlier, that nurse has 11 times more time to spend with other sick patients, feeling not so overwhelmed, So actually, stewardship isn't about adding to your workload. Often it's actually about improving your workload because it means you can send patients home earlier. It means you're not having to deal with prolonged admissions for resistant organisms. It means your nurses are not completely frazzled because every single patient's on IV antibiotic. So this is actually something that will help all of our overwhelm, not add to it, if we just think of it in that way, if you take that lens.
Yeah. Thanks, Dr. Urquhart. On average, it takes around 22 minutes to prepare and administer an IV antibiotic, compared to 80 seconds for an oral antibiotic. So it's coming to the end of the week, so I'm not going to do the math. So that's I'll leave that to you to add up for your own clinical areas. But we looked at a time and motion study locally over the space of 5 years, and our hours dedicated to IV preparation and antibiotic administration doubled in that time. So our latter time scale was 17 hours of nursing time in a 24-hour period in one surgical ward dedicated to the preparation and administration of antibiotics. So as Dr. Urquhart was mentioning, it also contributes to our capacity and flow. So we can allow patients to be discharged home sooner, it impacts their psychological well-being as well. They're much safer recuperating in their own home environment, less risk of healthcare associated infections and subsequent and possible further antibiotic exposure. So it's a real win-win when we think about IV to oral switch.
Thank you. That's really, I'm sure at these times of pressure, and particularly heading into winter, it would be a huge benefit to release capacity that way. Any other questions or comments?
Am I still muted?
No, we got you.
Oh,
Don't touch anything.
I'm so sorry. Another really good, it's really great, Lynn, to put it down to brass tacks so people can see the benefit. Another really great number to think about is when we're thinking about shorter durations being better than longer. So pneumonia only needs 5 days and not 7. And by doing that, you're actually reducing our numbers by 30% of use of antibiotics. Just that simple move from 7 days to 5 days, it is worth looking up the duration bit of every antibiotic we're prescribing, because I think by doing not a lot, we could actually find ourselves reducing both the pounds, but also improving care, because there's side effects associated with every single day of antibiotics, and also improving our flow. So main message is actually a congratulations message, because we are doing very well in Tayside. It's just looking at what additional gains can we make.
Yeah, and I think the congratulations also need to be extended to your whole team, because being at the top of that chart when it comes to the use of access antibiotics, I'm sure was not an easy feat, and for the leadership and diligence around that from your team is obviously no small part of that success. So thank you very much for your work and leadership across the organisation, a big organisation, on achieving that.
Yeah, Sarah, I was just going to add to that you know, there is evidence that when you have infectious diseases doctors involved, that it improves all of this. And actually, I was just thinking about that chart that was presented about the different regions. It may be, you know, like in those big regions, only one of their hospitals has actually clinical infection doctors that are available on site and that are going out and building relationships and doing this kind of stuff. And so ID used to be something that was only in certain hospitals, but actually, is that okay? It probably isn't, because it's such a big thing. And actually, every hospital needs a clinical infection service, not just somebody, you know, that they can seek advice on, but actually people that are out there seeing patients and kind of driving stewardship like Bussy and the team are.
Yes, I know my life is much better for having many infection doctors in it. Anybody have any further questions? You've got 10 minutes to get to your next clinic or meeting. So with that, then we will adjourn this. Thank you very much to Jo, Heather, Brucey, and the wider team for putting that together. And here's to the next grand round.
Thanks, Sarah. Thank you.
Thank you.
Alrighty, bye.
Bye.